So thank you, Ed, for inviting me in this distinguished panel. Ed has been very brave inviting a native speaker of French. French being an official language of NATO could have been all in French, but no, I did in English. So my question today that I will address is, cardiac surgeon pilots, are we able to let them fly again after they have been by a cardiothoracic surgeon through? And as I'm from Switzerland, we have a very special system there, with most of us is not familiar with. It's the militia system. So this means that I do have two jobs at the same time. I'm a CT surgeon and I'm a flight surgeon at the same time. So I wear different hats. When I have to refer a patient, I can refer it from myself to myself, or it's better to refer it to another one. But function-wise, I do have both functions. So I do wear scrubs currently at the Royal Brompton Hospital in London, but when I'm on duty, that's the kind of chaps I am going to look after. No, this is not mine. Do you agree? Well, it's not my question. It's not my multiple choice. And this is not my... Much better. All right. My airbase is in Sion, and the type of aircraft I'm looking after the pilots, this is F-18 Hornets pilots, and this is the mission type to have, so high performance and some sort of G forces involved. Yes, so the main topic for me today with you is to blend cardiac surgery and flight medicine, and to make best possible use of the two hats I'm wearing usually in my life. My plan will be to have some background information, then I will explain some of my methods, give a case report to have some sort of illustration of my topics. Then I'll discuss the operations and make an overview of the kind of operations and what is the implication of those operations in operational time for the pilots after having undergone surgery. And I'll come to some conclusions, and this is the badge of my unit. Now, we have been asked if we could kindly provide some multiple choice questions for today's panel. My question will be this one. Air 4 pilots are grounded after cardiac surgery. True, depends, restrictions apply. Congenital disorders are disqualifying. B, C, and D correct. We can think of it, and at the end of the presentation, we'll hit the button. All right, aortic valve surgery to start with. It's rare among active pilots, but it's still a reality. And once we face it, even if it's not our daily business, we really have to take the right decisions. If we ground him permanently, well, it's quite a mess for the invested money, and to ground a pilot is really not nice. On the other hand, if we let him fly again, it's fair enough, but we have to take the responsibility and say, I'm confident you're gonna make your mission, you're gonna do it well, you will not harm the aircraft, and we can be able to use aircraft and air crew after your next landing. Our population, mostly young patients, active flight duty patients, so the highest prevalence of disease we are going to face as cardiac surgeon when they are referred is bicuspid aortic valve. Bicuspid aortic valve, by the way, is the most common congenital heart disease, if we take it at large. We have seen the numbers of the prevalence goes up to 2%, so we are 150 here in this room. 3 of us, statistically spoken, have a bicuspid aortic valve. The background where we base our decision in the Swiss Air Force are the civilian aeromedical regulations. They say that bicuspid aortic valve may be assessed as fit. And in our Air Force assessment pathway, we have introduced pre-assessment echocardiography for the first time checks. It was not always like that. That's why we have had 2 pilots that were enrolled, got the job. One was a Tiger pilot, the other one Mirage pilot, and they had bicuspid aortic valve, and they had to undergo surgery after that. More to that a bit later. So we changed our policy. We had now a very compulsory echocardiography at selection. And if we have waivers, if we have applicants with a bicuspid aortic valve, this is, in our Air Force, a disqualifying condition. One has to have in mind, you are all from large countries with large air forces. Our Air Force is a small one. We have about 600 pilots. So if one is going to drop out after selection, after his qualification, it's a huge drop in the output. And it's a lot of cost for nothing, and also false hope to the pilot, because we could have reoriented him early on to something which is able to do lifelong. So it is, in our Air Force, a disqualifying condition. All right, so confirming flight licensing after aortic valve replacement, that's a challenge for two groups of people. Cardiac surgeon, that's me, and the authorized medical examiner, the Aeromedical Institute. All right, the two of them, they will have to work together. We know it, only the AME is authorized to determine the flight state of pilot, not the cardiac surgeon. But we will see, the joint venture of both of them is essential to achieve our goals. From the perspective of the post-operative point, we have had the operation, everything went fine, pilot is operated. What is the main issue when we want to fight for flight? Wouldn't like to speak of grounding pilots, I would like to speak what can we do to make them fly again once they've had an issue. What do we have to look at? What are the main criteria? Well, one physical parameter that we have and that the civilian flight doctor doesn't have is the high G load environment. The high G load environment, this is exceptional physiological parameter, and this has to be considered in the post-operative follow-up and what we are going to allow the pilots to do or not. Fighter pilots, if it's at selection, how are we going to orient them? Rotary wing, transport, no high performance, question marks. And civil aviation, if he gets his license, civil aviation, well, are you going to let him go the Red Bull race? Not sure about that. Well, no pilot after his operation wants to have this. Huh? That's an explanted aortic valve, prosthesis, Medtronic one, that is completely knacked, useless. We don't want our pilots to have an early structural valve disease, that they have to go too early reoperation. Still bear in mind, sure, they are pilots, sure they want to fly, but first of all, when they invest, they are patients, and we need to do what is in the patient's best interest. So have a life expectancy of the implanted device that we need to optimize in certain ways, taking in consideration what the pilot is going to do with it. What the pilot wants instead is that. By the way, all the pictures are of mine. Beside two of them, I will say, for the disclosure, that are not from myself. Now, the background for licensing procedures have been historically joint aviation authorities with the regulations, with the flight licensing part 3, medical. And currently, we are in the main change with all the EASA implementation, department of the EASA, and also ICAO published aeromedical data. We'll see why this may have some implications, especially in the legal point of view. Because as we all know, when we take decisions as a doc or as a surgeon, we do things because we know they are good, we do other things because they are evidence-based, they are good, and we do or do not do the rest of the things because there are legal reasons. I reviewed our current aeronautical, surgical, medical literatures, the regulations, and I made a case study on two Swiss Air Force fighter pilots. As I said, they were on Mirage and on Hornet. Yeah, what does the EASA say? In the latest edition, 2011, they say that back to flight duty is possible 6 months after cardiac surgery. That's the wording of the text. We have to bear in mind the 1% safety rule for safety requirements, and yesterday's day was dedicated to that. But still, this is the main safety rule, is the 1% safety rule, and we have to fit all our risks, as we all know that we will never have the zero risk situation, but we will have an acceptable risk. And what is an acceptable risk? Well, it has been by consent defined. That's the 1% cut off. And what is the most dreaded complication in flight medicine? What do I really want to avoid my patient or pilot to experience once he is on the cockpit? Thromboemboli and rhythmological disturbances. Why is that? Because those will lead to a sudden incapacitation. Those will endanger the flight cell and the people on the ground. So as a very short overfly of the 1% rule, we all heard about it, but just to refresh, it has been established that in the worst case scenario, there will be one medical reason to threat a flight in 1 billion of flying hours. And they have defined it as 1 hour as an average flight. So 1 billion flying hours, billion flights. One reason of a threat should be medical, but not more than that. So this means that for an air crew, and 1% risk per year is an acceptable risk. So if you follow me further, after successful tissue aortic valve replacement, and this is true, the manufacturer have made huge progress in their devices. I won't cite brand names, but basically there are porcine, bovine, stented prosthesis that you can use for your patient. Then you have stentless prosthesis. This is porcine. It's the root of the pig's heart outflow tract, and it looks like a homograft but just a pigograft. And the rest can also be a Ross procedure to be considered. In the setup of a high flow profile, because each device has his indications and contraindications. In the setup of a high flow profile, like we will likely encounter in young population, practicing sports, and if you've all those who have pulled G's in an aircraft, they know that the cardiac output does indeed increase significantly in these moments. You'll need a valve that copes very well with those conditions, especially that the slope of increase of transvalvular gradient is as flat as possible in the high output range. And now, the best valves are really the stentless one. That's why when I have patients in young age referred for the classic bicuspid replacement, furthermore pilots, this will be a stentless subcoronary scalloped valve that I really implant there. And as mentioned before, you don't see the difference on the echo. A stentless valve implanted, you don't see the difference on the echo anymore. It's so smooth to the blood and so smooth to the outflow tract structures. We all have in mind, we remember from physiology for the heart function in the pump systolic diastolic cycle, the ring, the outflow tract ring, the annulus isn't static. It has a motion within the root and the sinotubular junction relationships, and the ring itself does move, and the commissures as well have a motion who are helping getting a minimal leaking backflow at the closure mechanism. So that's the reason why the stentless valves are really superior to everyone, all the others. But more details later. So the follow-up schedule plan after tissue AVR will be 6 months post-operatively. We'll have the first check, and this is the first window for opportunity to say fly don't. Annually, and this is according to PartMed schedule plan from the EASA revised prescriptions, and after that it will come back to 6 months if the pilot is over 40, single pilot commercial transport with passengers, or class 1 over 60. And for the class 2 certification, the same principles apply as for the class 1. And it has to be conducted by a cardiologist that is acceptable to the aeromedical section. So it's not the flight surgeon alone who decides, but he will have to liaise with AMS, acceptable cardiologist. And the follow-up investigation will have to include mandatory points. 1 to 8 are mentioned here. The function of the valve with the pressure gradient, the flow patterns. We do not want to have turbulent flow transvalvular. Dimensions of sinus portion. Why is that? Because turbulent flow can create microemboli, and those microemboli may be at risk for sudden incapacitation in the pilot. Dimension of the sinus portion, the aorta needs to fit some criteria, and the other heart valve needs to be normal. Heart chambers, left ventricular muscle mass, ejection fraction, and rule out written disturbances. So the requirement for the aortic valve from a formal point of view, it must be a bioprosthesis. EASA in the latest formulation says that mechanical valve may be acceptable. This is not an option for Air Force. No restricted cardiac function, no cardioactive medications. There will be a limitation for the G straining conditions. In our Air Force, the 2 pilots we've had, we limited them to 3G. It's just a value that will allow them to fly normally ferry flights alone, but they will have a multi-pilot limitation. Otherwise, they will have a non-ejection seat aircraft limitation, and they won't fly fighter jets anymore. We retrain them for transport. operations, which is a two-man cockpit anyway, and they did very well there. Class 2, same thing. Without safety pilot, it might be applicable, depends on how it is, and I published this data 2 years ago. Yeah, the stable anticoagulation, as the IASA is starting to play the part of mechanical valves, this induces the whole panel of anticoagulation. And their wording of the IASA, and it's very questionable in my eyes, seeing from the practice and daily practice in the hospital, and my patients when I follow them up, they say stable anticoagulation mandatory. Well, what is stable anticoagulation for them? 3 things only, 6 months. INR, 5 values within the 6 months documented, and 4 of them should be good. It's very optimistic to believe that those patients have efficient anticoagulation just with those criteria. That's wishful thinking, of course, that's hoping, but no facts at all. I would not let my pilot fly under those conditions. So I suspect there will be some homework to do more to finalize the IASA regulations, but let's talk to that later on. Mitral valve surgery, mitral valve leaflet repair for prolapse is compatible with fit assessment, provided the left ventricular function is satisfactory, the dimensions are not increased in cis and dia, and there is not more than minor residual mitral regurgitation. Here, once again, this is the IASA wording. They say minor. Basically, among surgeons, and this is definitely a surgical topic, among surgeons it's mild, moderate, or severe, or trace, but minor is not a word used by the community. But the IASA uses it, so once again, let's think about that for later on. A repair of the mitral valve, plus minus inclusion of the left atrial appendage exclusion, while in 2002 was compatible with recertification only when the left atrial appendage was resected. 2008, ICAO, the left atrial appendage amputation may be an advantage. And now in the last revised text from 2011 in the IASA, well, it's not even specified anymore. To think about that. A mitral valve replacement is not specifically mentioned in any of the current manuals. It was a disqualifying condition in the ICAO 2008 published one. Aorta will leave the heart and go outside of the heart. Let's follow a erythrocyte and go in the aorta. Size does matter indeed. And here, based on the American College of Cardiology and American Heart Association guidelines, they were published 2010. And very good publication is this one that has published in Circulation 2011 as well. Well, this patient I have operated on a couple of months ago. So the head of the patient is here. The feet are over there. That's left side where I am. And that's the right side of the patient where I am, and that's the left side of the patient with the assistant. This is the opened sternum. We have the aortic root here, 5.5 centimeters, slightly on the big side, and descending aorta is 5 centimeters. All right, that's very illustrative. Was a young lady, she was in her 40s. I'll tell you more about the diagnosis if we've got time. Well, size and overview. We have to have an overview and have cutoffs at certain points. I'll go from the lowest to the highest. Any patient with an aorta, ascending aorta above 5 centimeters needs to be treated. But this cutoff size goes lower and lower and lower. And the further they revise the guidelines, the lower the diameter gets. Why is that? Because we have more insight in genetic disorders. We have more insight in media degeneration. We have more insight in some underlying disease that are not clinically manifest as a classic Marfan, that are like low bruit, but still killers at low diameters. So you may miss the diagnosis and you may miss the referral to the surgeon if you're not aware of it. That's just the thing. And the awareness starts increasing, and the highest the awareness, the lowest the diameter for operation, which is good, more to do. 5 centimeters if there is any connective tissue disorder or a bicuspid aortic valve. And we are back by the bicuspid aortic valve. And furthermore, if it's 4.5, concomitant aortic valve surgery, and it goes down to 4 centimeters if it's a woman with a Marfan syndrome, especially if she is in bed, she wants to have kids. The aortic arch cut off at 5.5. So an operated dilation of the aorta is disqualifying condition unless the post-operative subject has fully treated hypertension and excluded any coronary artery disease. personally, those aortas are sick. There is a mechanical problem in those aortas. I do not think that those patients should fly any high-performance aircraft and treat even more the aorta, who is already now struggling to maintain the normal blood pressure in normal geometry. Genetic disorders, the Marfan one is the very famous one because we can spot it in the tube, but Ehlers-Danlos, Lowry, Loeys-Dietz syndrome, TGF mutations are all parameters that we have more and more taken account. Who knows, maybe in 10 years we will all do a genetic screening on our candidates. Usually connective tissue disorder, they should all be assessed as unfit. Bicuspid aortic valve, by the way, I would consider bicuspid aortic valve not as a disease per se. The bicuspidity of the valve is only the manifestation of a sickness of the aortic root and the beginning of the ascending aorta. It's a media problem, it's a matrix metalloproteinase problem. The bicuspid aortic valve is just the clinical presentation of it. We fix it because we change it. Take the old out and stitch a new in. But we didn't treat the disease. It's like a palliative treatment. Very efficient, though, but it's palliative, the underlying disease still being there. Do we want those pilots to be exposed to high-G environment? We have to think about it. Of course, there are many jobs within air forces. We don't need to expose them all to that. A coarctatio aortae can be unrestricted certified if he has been operated between 12 and 14 for obvious reasons, and he has to have a transthoracic echocardiogram follow-ups as a function of eventual bicuspidity of his aortic valve. Any concomitant dilation of the ascending aorta is a disqualifying condition. There is no data about post-operative evolution under high-G environment. For Air Force candidates, that's disqualifying. Tetralogy of Fallot, we just heard something before that. Well, as a reminder, it's a VSD, it's a stenosis of the pulmonary, the aorta is overriding, and the right ventricle is hypertrophied. Control population on the top line here, and that's the operated patient group, so they do quite well. 10% less as the normal population. If we break it down over the years, we would fulfill the 1% safety rule for them in the probability of survival. But what is the problem of congenital heart diseases? Arrhythmias. And we know that we don't want arrhythmias in a cockpit. And the problem is the arrhythmias. And they are more prone to arrhythmias. They're much more exposed to the risk of arrhythmias. And we see in this graphic published by Gatsoulis, also a fellow from Royal Brompton Hospital a while ago, that the ventricular tachycardia is an issue, sudden death is an issue, and atrial flutter fibrillation as well. So operated before the age of 12 with an evidence of no residual right ventricular hypertrophy, no pulmonary regurg, no ventricular arrhythmia, if you demonstrate all that and it's regularly monitored by a cardiologist acceptable to the aeromedical section, it can be initially even unrestrictedly certified, provided he's below 40. If he's above 40, he will not be compatible with the unrestricted certification for an Air Force appliance, disqualifying. Persistent ductus arteriosus has a very low 25-year-old mortality of surgical closure. The PDA is associated with bicuspid aortic valve, with subaortic stenosis, with pulmonary stenosis, with aortic root disease. And what the ICAO stated is that in the absence of those 4 points I mentioned, unrestricted certification might be considered. If one of you has been in theater when we close surgically a persistent ductus arteriosus, we notice how rubbish the quality of the wall of this ductus is. It is like a wet scone, like a wet biscuit that has been draped in it. And when you stitch and you put your sutures there, it just tears through the material. It's an extremely poor tissue quality. Once again, ask the question, do we want them to be in the cockpit? Not quite sure about that. Cabbage. Well, licensing requirements of the coronary artery bypass grafting, we have already heard a few things there. It's possible to be class 1 again, not before 6 months, and it will be a multi-pallet restrictions indefinitely, provided that he's asymptomatic and has no anti-anginal medication, that his cardiovascular risk factors are all addressed and documented as such: sugar, fat, tobacco. The left ventricular ejection fraction should be above 50. He should demonstrate an exercise ECG to Bruce stage 4. And there is an angiographic criteria. Well, at the time of the index event, there should be no more than 50% stenosis in any major non-treated vessel or grafted or stent. And the left main or the proximal left anterior descending should not be more than a 30% stenosis. There should be no untreated stenosis above 30% of the left main or proximal LAD. If, then it's not acceptable for certification. Now, surgeon's point of view. If I put a graft on a vessel that is diseased below 70%, or for a left main below 50%, what would happen to this graft? I will have a tremendous concurrential flow to the remaining flow through the vessel and my beautiful graft. What's going to happen? My graft will shut down. So I've done an operation, I have opened coronaries, for what? Nothing. So this regulation does make sense in theory and on paper, and it looks good, but it's not practicable in theater. We should think about it as well. That's maybe one of the seeds we can put here during this convention. And the annual follow-up by cardiologists, of course, is mandatory. All right, so that's the blue sky over Switzerland and the beautiful Matterhorn. This picture is courtesy of Swiss International Airlines. My conclusions, 3 slides. Yeah, choose a prosthesis for aortic valves with an optimal high flow profile. Stentless the best. New designs, Ross procedure, consider it. And as you know, young patients, they will come back for surgery. So start the planning of the redo surgery already at discharge. Know what you're looking at, because what do you want is to catch your patient when he has objective criteria for structural valve deterioration, and not when the patient catches you because he's feeling sick and unwell and you've missed the train because he's already too much in deterioration and the heart has taken harm of it. Why is that? Because if I plan elective surgery in an otherwise fit patient, but that does fulfill the criteria for redo aortic surgery, his risk compared to the initial operation, as published by Vogt et al., is 1.4% more only, which is absolutely acceptable to the pilot. And in the civilian regulations, when we go to our meetings, what you will see is that the criteria for indication of aortic primary surgery come always down and down and down, away from the symptomatic patient to the objective criteria meeting patient. And the aeromedical examiner is the co-pilot of the cardiac surgeon, and he should liaise with the cardiac surgeon for that. So timing of surgery. Congenital cardiac and aortic diseases, civil and aviation industry say, well, best risk profile may be assessed as fit. We say they are not. Once again, the AME's co-pilot is the cardiac surgeon. Please liaise before making a plan. And to finish, coronary artery bypass grafting, best risk profile may be assessed as fit with multi-crew restrictions. And repetitio est mater studiorum, the AME's co-pilot is the cardiac surgeon. This literature helped me making this talk. This concludes my briefing, and I thank you for your attention.